Perfect.
All right, okay.
You
So
can
after a
start.
lot of struggle, I managed to. Okay. Good evening, everyone. So, as the first was saying, this is a very important topic, and exactly a bit confusing also. So, in the example, they will be giving you a picture of a rotom, and they will be asking you about your interpretation or your management plan. So in this session for next half an hour, we'll be talking about Rotem. So I'll just go ahead a little bit of basics of Rotem so that you guys will be acquainted with what does it mean, and if you are given a scenario, how to interpret it. So Rotem stands for rotational thromboelastometry. It is a point of care therapy directed information on coagulation. The aim for Rotem is to optimize the transfusion of blood products, and also in clinical studies it has shown that it has reduced the transfusion requirement and transfusion associated complication. Now, real time and graphical, that's what you get in a Rotem. It gives you an idea about the clot, that is the time of formation of clot, the strength of the clot, and how does it gets breakdown or broken down. So it's not only about one phase of the coagulation, it is a holistic representation of the coagulation at different phases at different times. So how does it is carried out usually? So the whole blood is taken and it's put into a cuvette with calcium in it, and a pin, which is you can see here, is suspended into that cuvette and it starts to spin. The pin rotates gently back and forth in the liquid blood. Initially there is no resistance, but as the blood starts to clot, there is an increased resistance there in the cuvette, and that modifies the movement of the pin, giving you a particular shape of the curve, which is we call it as a temogram or the Rotem curve. Now there are different curves that we look at based on the reagent used in the cuvette. Usually there are 4 or 5 specific curves that is represented in that figure. So first of all, the first one is called as the FIFTEM, which is fibrinogen oriented. So in FIFTEM you get more idea about the fibrinogen as the factor of coagulation. The second is called as the XTEM. It represents the extrinsic pathway of the coagulation. The third one is a INTEM, which represents the intrinsic path of the coagulation. Um, the fourth one is called as EPTEM, which is representative of a situation where aprotonin is added into the blood to enhance or to decrease the clot fibrinolysis. And the last one is a heptem, which looks at the effect of heparin by putting heparinase into the system so that it breaks down the heparin in the blood. And whatever you see is the representation of the current coagulation status of the blood. So 5 channels we say. First of one is the FIBTEM or fibrinogen oriented channel, XTEM or extrinsic pathway, uh, INTEM is intrinsic pathway, EPTEM is more looking at the fibrinolysis component of that. You add a aprotonin into the blood. And the fifth one is the HEPTEM or heparin channel, where you neutralize the effect of heparin by putting heparinase into the blood. So 5 channels, okay. Um, Now, a little bit of theory that you need to understand, because the clot formation or the whole process of coagulation is divided into majorly 3 phenomena. One is a initiation, amplification, and propagation. Between amplification and propagation, the phase of fibrin formation happens. So the initiation happens with the tissue factor, which is the main starting point for the coagulation, or it is a procoagulant factor. Tissue factor exposed to the blood causes factor 7 activation, which produce small amount of thrombin. This is followed by the amplification where platelets and cofactors are activated, and hence other factors get also activated, and there is platelet aggregation, and there is propagation of the clot afterwards with a common pathway. Um, so the theoretical part of the coagulation is usually we read as two different pathways, but it's not as simple as in this. The in vivo mechanism is pretty complicated, but for our easy understanding, we think it is an intrinsic pathway and there is an extrinsic pathway which converge together for a common pathway. In the common pathway, sorry, factors 2, 5, and 10. In the intrinsic pathway, you have factor 8, 9, 11, and 12. And in extrinsic pathway, you have majority factor 7. So the common pathway leads to formation of fibrinogen and then fibrin clot. So this is the usual concept of coagulation that you guys know. Um, Now the most important factor in the whole of the coagulation system is the fibrinogen. It is the most prevalent clotting factor and the final clotting factor in the common pathway, as we discussed. Interestingly, fibrinogen is consumed the fastest when the clot is activated. So fibrinogen is the first factor to fall critically low, uh, becomes critically low in a patient who is bleeding or hemorrhaging, because the body uses up the fibrinogen, and the first factor that decreases in such a situation is your fibrinogen. The fibrinogen levels are usually higher in pregnancy because pregnancy leads to delivery of the baby and there is high chance of bleeding. So as a preventive mechanism from the nature, we have a higher fibrinogen. This is the only coagulation factor which is higher in pregnancy. Now, early fibrinogen replacement assists rapid correction of coagulopathy and reduces transfusion of other blood products. This has been proven with multiple clinical trials also. Sometimes they ask you what are the sources of fibrinogen in clinical practice. So usually there are three important sources: fibrinogen concentrate, the highest amount of fibrinogen you find there, followed by cryoprecipitate, a little bit low, and if it is a apheretic cryoprecipitate, the concentration is slightly high. The least you find in a fresh frozen plasma. Now, the major coagulation determinants in major hemorrhage are the coagulation factor for sure, but there are other things that determine the patients whether they are bleeding, not bleeding, whether they will continue to bleed or not. Apart from the coagulation factor, there are other factors are very, very important which cannot be measured by your Rotem. So you need to know what are the things that cannot be measured by this point of care coagulation test. First of all, hypothermia is a major barrier for coagulation. If the patient is hypothermic, then the coagulation whole cycle gets delayed and the patient continue to bleed. So optimization of the temperature. Unfortunately, the Rotem system measures all the coagulation factor, and studies happen at room temperature. The patient's blood may not be at room temperature, so it may not represent the exact problem that is going on if the patient is hypothermic. Second is hypocalcemia. In this test, calcium is added to the sample, thus correcting for platelets for patients with hypocalcemia. So you cannot evaluate a patient with hypocalcemia that the bleeding disorder is because of hypocalcemia. That's the problem of Rotem, because calcium is added into the blood and it is corrected. So you will not be able to know whether hypocalcemia is one of the cause for bleeding for that patient. It is not useful if the patient is on therapeutic, or it is not useful for monitoring of therapeutic efficacy of anticoagulants such as heparin, low molecular weight heparin, pentasaccharides, nanoparode, or anticoagulants which have direct thrombin inhibitor or the NOACs. It is not useful because it is not a quantitative value saying that um, the patient is more coagulopathic or less coagulopathic if they are on anticoagulants. If the patient is on a platelet inhibitor, they will not tell you with Rotem. So Rotem is useless unless you are on a platelet inhibitor such as clopidogrel, aspirin, or a GP2B3 inhibitor. Patients with uremia, patients with von Willebrand's disease, you cannot find an abnormality with Rotem. Again, platelet dysfunction, functional issue with the platelet may not be appreciable with Rotem. So these are the drawbacks or limitation of Rotem. And also patients who are acidemic, also in those cases acidemia is one of the varicose triad thing that prevents coagulation to happen. So this system cannot determine whether the patient has acidemia causing coagulation issues. So these are the drawbacks or limitation of Rotem or point of care coagulation testing. So you need to know about this. This is a usually asked question in the exam. They will be asking what are the things or what are the coagulation abnormality that a Rotem cannot detect for you. Now there are two types of Rotem where one checks with or without heparin. So if the patient, if you have cardiothoracic working in a cardiothoracic unit, so you may have a machine which uses a cartridge for heparin or has an additional channel of heptem. It is called as the complete plus hep channel. So this is a different channel. So there are two different cartridge for two different result to find. So the first one is usual Fiptem, Extem, Intem, and Aptem. Instead of Aptem, in a patient who is heparinized, you may need this channel. So it is called as the complete plus hep. So Fiptem, Extem, Intem, and Heptem. So you look at heparin effect in this type of cartridge. The bottom one, this type of cartridge, but the top one does not give you a heparin effect. So if the patient is on heparin or is being anticoagulated with heparin, then you have to choose this cartridge and use this. And if the patient is not on heparin, then you have to use this cartridge or use this interpretation. So this is all technical things. So whatever cartridge or what machine you use, depending on that, it varies. Now going into a detail of the Rotem. So first of all, I told you about a demogram or a fraction or one fraction of the diagram is called as the extem. It represents the extrinsic pathway. It contains the tissue factor and other factors for coagulation. It assesses the combined effect of fibrinogen and platelet. Just be careful what I'm talking about. This is very important. The extem looks at both platelet and fibrinogen, right? Both platelet and fibrinogen. It's not only one thing, okay? Abnormal clotting times are used to determine if there is a clotting factor administration requirement. So it also looks at clotting factor deficiency. So fibrinogen, platelets, and clotting factor. Three things can be seen here. Okay. The next one is FibTem or fibrinogen channel. So the FibTem channel contains the same reagent as XTEM, but in addition to that, it inhibits the platelets. So the platelet effects are neutralized here, and whatever you see in this channel is because of fibrinogen. So FibTem looks at the effect of fibrinogen. So if the FibTem channel is within normal range, then you need to look at the difference between FibTem and the XTEM, because as I said, the XTEM measures both fibrinogen and platelet. The FibTem measures only platelet effect. So if this is normal, the FibTem is normal, where the platelet function is neutralized, and you find abnormal XTEM here, that means the fibrinogen is normal, but the abnormality is because of the platelet. Do I make sense? So in the FIPTEM channel, whatever you see is because of fibrinogen problem. Then platelets are totally neutralized. So there is no platelet effect that can be seen. Whatever abnormality you find is fibrinogen issue. If this is normal and the extem is abnormal, that means fibrinogen is normal in the blood. The abnormality in the extem is because of the platelet. So that's how you delineate. If the extem is abnormal but the fibtem is normal, then the problem is because of platelet. All right. There's a question in the chat box. Can you go to the previous slide, extem? Yes, we can. Uh, close. Sorry. Yeah. So explaining again, this is the extem channel. So it looks at both the effect of fibrinogen and platelet. So whatever you see here is the combined effect of fibrinogen and platelet. In the FIB10, whatever you see is because of fibrinogen. So if the patient has a normal fibrinogen and an abnormal platelet, then your extem channel will be abnormal. If the patient has normal platelet but abnormal fibrinogen, then both extem and FIB10 channel will be abnormal, because this channel looks at only fibrinogen and this channel looks at both fibrinogen and platelet. All right. INTEM, the INTEM channel assesses the intrinsic pathway. So abnormal clotting time in this channel are used to detect heparin effect, like APTT, similar type of thing. So if there is abnormality here, it is because of heparin effect, or it can also used to be look at protamine excess. It may also, because anything that is abnormal, that causes a abnormal intrinsic pathway it will be shown in this channel. So whether it is heparin, whether it is protamine excess, whether it is clotting factor deficiency, whether it is a fibrin polymerization disorder, or any other anticoagulant affecting the intrinsic pathway, you will find a abnormal intent. Okay, intrinsic pathway problem, right? Now, why I'm saying protamine excess and heparin effect, I discussed about that, or I asked a question in the group earlier about this. We will take it later. The last channel is the heptem. So as I said earlier, what happens is in heptem we neutralize the heparin. So whatever effect of heparin is totally taken care of. And whatever you see is totally because of other things than heparin. Okay. So suppose somebody is on heparin, then the intem channel, the clotting time will be very prolonged because of heparin effect. But that effect will be corrected in heptem, because you have neutralized the heparin. You have totally discarded the heparin effect. So whatever is there in heptem is not because of heparin. It is because of something else, right? So if you have a prolonged clotting time in intem which gets corrected in heptem, that means it is heparin effect. But if you have a prolonged coating time in intem and also heptem, it is not because of heparin, it is because of something else, some other inhibitors. Okay, so that's what you need to understand. So the heptem channel contains heparin, is it destroys the heparin. So this channel demonstrates heparin effect via an improved clotting time when compared to the intem channel. So in intem you will find a heparin effect. In heptem you will not find a heparin effect. If this occurs, then protamine is indicated. Like if the clotting time is prolonged here in the intem and it gets corrected in the heptem, that means there is a heparin excess and you need to neutralize the heparin with the protamine. So you give protamine to that. If extensity, so remember extem, the channel here, if the extensity is normal, that means your platelet and possibly the fibrinogen are normal, but the intem and heptem city are prolonged. So the intem city is prolonged, the heptem city is prolonged, but the extem city is normal. That means the patient has protamine excess. Okay. So normal city in extem, abnormal in intem, and heptem means you have protamine excess. So the question that I asked in the group earlier, how do you determine a protamine excess? So for protamine excess, what will happen is your clotting time is normal in the extem, but it's abnormal in both intem and heptem. Now, how is it different from other inhibitors? So if there is other inhibitors present except heparin, the clotting time will be prolonged in all the channels 1, 2 and 3. All the three will be prolonged. But if it is protamine excess, then both intem and heptem are prolonged with a normal extem. Okay. Hope that makes sense. We'll go to some examples and that will make it a bit clearer. Now the parts of a rotem. So initially you looked at the clotting time or CT. This green part is the CT or clotting time in seconds. So it represents the initiation phase, that is the time from start of measurement until initiation of clotting. So you started measurement here, this is 0 time, and the length of that is the clotting time. If it is more, that means the clotting time is more. If it is less, the clotting time is less. So it represents the time for clot initiation, thrombin formation, and startup clot polymerization. So prolonged CT causes the causes for prolonged CTs are clotting factor deficiency, heparin effect. We talked about that, and you have to see how do you know which is because of what. So heparin effect will be corrected in heptem, but if it is due to any clotting factor deficiency, it will be not corrected in the heptem. We look at alpha angle. So alpha angle represents your what do you call clot initiation or clot strength. The higher the angle, the better it is. The lower the angle, the worse it is. Okay. Clot formation time. So clot formation time is clot formation time in second, which represents the pink part. So when you have, this is a time initiation of clotting like 2 millimeter, where the height is 2 millimeter until the clot formness goes to 20 millimeters. So that part is the clot formation time from 2 millimeter to 20 millimeter there. So that duration is called as the CFT or clot formation time. Again, it represents the fibrin polymerization, stabilization of clot with platelet in factor 13. If there is a deficiency, then the CFT will be prolonged. Usually, it's not clinically important. We don't look at the CFT usually. Next, maximum clot formness. This represents a millimeter height. Um, so it represents how strong or how firm is the clot, and increasing stabilization of clot by polymerization of fibrin and platelets and factor 13. So that MCF will be low if you have deficiency of fibrin or factor 13. Okay. Now, important thing to look for is the A5. So it represents the clot firmness at 5 minutes post clotting. So if you start clotting here, 5 minutes post clotting, what is the clot firmness? What is the height? All right. So that represents the A5. This is an important number. So A5 we look at 15. So A5 represents the clot initiation or initial firmness of the clot. Okay. I'll go to in detail in subsequent slide. Then you look for maximum lysis. So percentage reduction in clot formation at a particular time. We usually look at 1 hour or 45 minutes, right? So reduction in clot formness after maximum clot formation. This is the maximum clot formation, and we look at a particular time. How much is the clot lysis? Okay. Stability of the clot. If maximum lysis is less than 5% at the measurement time, this is normal. But if the ml is more than 5% at or within 1 hour, then it is a sign of fibrinolysis. Massive fibrinolysis can result in a long CT or clot formation time or a small or absent disappearing A5 or A10 in all channels except eptem, because in eptem you give aprotoniin, which neutralizes the fibrinolysis. So that's how you know. So in if EPTEM, if the times are getting corrected, but rest of the sorry rest of the places it is abnormal, then it is a fibrinolysis issue. Now for prerequisite, the thing that you remember clinically is you don't treat the graph, you treat the patient. If the patient is not bleeding, you don't have to do a rotum and you don't have to treat it. But first and foremost thing is to optimize the basic needs for coagulation that we talked about, because rotem is very dependent on these, and it is measured at a normal condition where the temperature is body temperature, pH is normal, calcium is normal, and hemoglobin is normal. So you have to ensure that the patient is normothermic, pH is more than 7.2, normal ionized calcium, and preferably hemoglobin of 70. And then only you send the sample for a rotum, because all these are determining factor of coagulation and will affect the result of coagulation, but you will not be able to assess them through rotum. Okay, now interpretation. So first step, what you do is to check for a heparin excess. If the patient is on heparin infusion or the patient is on a CP bypass, suppose in between CP bypass the anesthetist come with a sample of blood to see in those cases. So what happens is in heparin excess you will have a intem clotting time more than 205, but this gets corrected in heptem. So the clotting time will be higher in intem, but it gets corrected in heptem. What does that mean? Is heparin excess. So what will you do is to give protamine just to reverse it, right? The second step is you assess always fibrinogen. As I said, this is the most important stage, and fibrinogen is the most important and earliest factor that gets depleted during bleeding. So you have to first assess the fibrinogen. Depending on what machine you are using and what setup you are in, there is a particular algorithm that we go. But in my setting where we look at FIPTEM A5 or at 5 minute, what's the FIPTEM height? If it is less than 9 millimeter, that means the patient is deficient in fibrinogen. As I said, FIPTEM looks at the fibrinogen. So that's the first thing you look for. If it is less than 9 millimeter, that means there is a fibrinogen deficiency. You need to give cryoprecipitate or fibrinogen concentrate to treat. So this is the first step you have to do. First step is the assessment of fibrinogen, or first if the patient is on heparin, you have to rule it out. And the next step is to assessment of the fibrinogen. Then the next step is looking at platelet function. As I said, platelet function is assessed in two different channels. One is a FIPTEM, the other one is a XTEM. But in FIPTEM, we neutralize the platelet and we look at only fibrinogen effect. If the clotting time is high both in FIPTEM and XTEM, you know that it may be due to fibrinogen or due to platelet or both. But if the FIPTEM clotting time is if the FIPTEM is normal and XTEM is abnormal, that means there is a problem of platelet. Okay, so that's what it is. FIPTEM A5 is normal, more than 9, but the XTEM A5 is less than 35, which is abnormal, or FIPTEM is low and the XTEM is low. Both are low, or FIPTEM is normal but the XTEM are low. That means there is a platelet deficiency. Okay, you need platelet transfusion. Next step is to look for other factors. Okay, factor deficiency, but the prerequisite is first you have to correct the fibrinogen. If you don't look for fibrinogen and correct it, then most of the channels will be abnormal and you will not be able to find the real reason for that. So you have to first look for the FIPTEM channel, correct the fibrinogen, and then go next step. Okay. So the fourth step, as I said, is to assess the factors. In this case, the FIPTEM, the FIPTEM A5 will be more than 9, that is normal, and the XTEM CT is more than 90, which is abnormal. Okay, you have corrected the fibrinogen, but still the XTEM state is still prolonged. That means your platelet is corrected, your FibTem is your fibrinogen corrected, but still you have a coagulopathy, which is because of the coagulation factors. So you give FFPs or prothrombinics. The last thing that you look for is SS fibrinolysis. Like if straight away, if the FibTem is more than 600 seconds, then this is a massive early fibrinolysis. It is happening in the early stages. So you have to give tranexamic acid, or in the curve, if the maximal clot lysis is more than 5%, then you suspect it's a fibrinolysis. It may be a bit confusing talking about this, but people who have used it, it will be very easy to look for, right? These are all numbers that you get in the report. When I go to the example, it will be more easier. Okay, now let's start. I need this to be a little bit interactive, and people need to answer, otherwise it will be very monotonous and I cannot gauge how people are, what they get out of it. Okay, so that's the first, sorry, that's the first example. What do you see? Any takers quickly? So we have 10 examples. We'll go quickly. All right, someone, last slide, please. All right. I'm not going to discuss if nobody is going to answer. Abnormal FibTem, which is not abnormal, as you can see. A5 is normal, 15, it's not abnormal. Yes, fibrinogen deficient. Sorry. Okay. Fibrinogen deficiency, protamine excess, abnormal FibTem, abnormal XTEM, CT need Iabp, DOACs. You cannot assess the effect of DOAC. CT prolonged, normal FibTem, fibrinogen deficiency, normal. Okay. Let's do this step by step, all right? First one. So FibTem. So as I said, FibTem shows the contribution of the fibrinogen. Platelets are neutralized in this channel. We discussed about that. Sorry. So in this case, the fibrinogen or FibTem A5 is normal. It's 15. So that's normal. Okay. So there's no issue with the fibrinogen here. Next channel that we see is the XTEM. So what do we know about XTEM? XTEM looks at platelet and clotting factor, including fibrinogen. Okay. Now in this case, the CT is prolonged to 110, indicates possible clotting factor deficiency because the fibrinogen is normal here, and either it is a platelet issue or a clotting factor issue. Now, platelet contribution is the difference in A5 between XTEM and FibTem. So look at XTEM is A5 is 36 or 35, and here is 15, and the difference is more than 20, which is pretty good. Okay, so the extra effect of platelet in excess of fibrinogen is from 15 to 36, which is 20. Okay, which is acceptable. So probably the platelet functions are good. So no issues with platelet. Now go to intem. What happens with intem is the clotting time is prolonged. So this means in the absence of heparin, because this patient probably is not heparinized, this channel is not necessary to guide transfusion product. But when you look at EPTEM, oops, sorry, it shows the clot stability, but compare the XTEM with the EPTEM and maximum clot lysis determining the fibrinolysis. So here the clot lysis is 0%, so no fibrinolysis happening. So EPTEM is used for fibrinolysis. The major effect here is either it is because of a problem of platelet which we think less likely, or it is a problem of coagulation factor. Okay, because the extem and the intem, both the clotting, the CT is prolonged. So it is an issue with the coagulation factor. So in that case, how do you treat it? You give fresh frozen plasma or prothrombin. So basically, how you evaluate is, first step, fibrinogen 15, which is normal. A5, we look at the A5 normal, so it is not a fibrinogen issue. Go to extem, the CT is prolonged. The CT is prolonged can be due to either fibrinogen or clotting factor or platelet, but we know that the fibrinogen is normal, so it is a problem with clotting factor or platelet. Now, because the A515 here and the A5 is 36 here, there is a quite a good amount of contribution from the platelet. So probably platelet is not the problem. It is possibly the clotting factor. The second or third step that you look for is the intem. The clotting time both in intem and extem are prolonged. That means it is a coagulation factor issue, which you will treat with FFP. The aptem is used to look for clot lysis. If there is no clot lysis, then that's what is your diagnosis. The patient needs FFPs. Okay. Now, second one, let's talk about this. What's happening here? Can you take us quickly? Okay. Somebody says, Venkata Ganesh says fibrinogen deficiency, fibrinogen deficiency, fibrinogen deficiency. A5 is less. Yes. I think now it makes sense. I hope people who are answering are can see. Now the A5 here is 7, which is marginal, like 5 to 20. So it is less, probably less, because I showed you that graph earlier, the table or the arrow mark, that we look at a A5 of around 7 as the minimum, or 8 is the minimum. If it is 7, then we are in trouble. Okay. So you have a 15 which is less than 8 or 7. That means there is a problem with fibrinogen. We know that already. Okay. Next step is extem. Now it is very hard to see the effect here because the fibrinogen is already deranged. So interpreting anything in extem, intem or aptem will be difficult because you have to correct the fibrinogen first and then look for the platelet effect. Okay. So in this case, what will you do is to transfuse fibrinogen to the patient. Okay. The only extra information that you can get in aptem is the maximum lysis, but it is 1%. So anything more than 5% is abnormal. 1%, so there is no increased fibrinolysis. So how will you treat it? You will supplement the fibrinogen here. Okay. Because with other channels, will not be able to interpret anything as long as you have a fibrinogen deficiency. Okay, so fibrinogen concentrate will give or cryoprecipitate, depending on that. You can supplement pool of platelet because you are not sure whether it is because of platelet and fibrinogen or just fibrinogen, just to make things a bit more problematic. So you can see this A5 is 7 and in the extem A5 is 17. So rise in the A5 is only 10, which may also be an indicator of platelet deficiency. So you need around 20 increase from that to there. A5 should increase from 7 to 27 to say that the platelets are adequate, and it's only fibrinogen. Because the increase is around 10, so it's not too high. But again, this is just a rough estimate. It's very hard to see how much platelet are contributing to this abnormality, as long as you have to correct the fibrinogen first. But again, we sometimes look at the difference. Difference is not too high. That means there is a contribution to platelets also. Okay. This one, any takers? So 35-year-old woman, gravida 5, para 4, suffers at PPH with hemodynamic instability, taken to theater for intervention. What products will you advise? So A5 is 10 here. Usually in pregnant patient, we want an A5 around 11. So if it is 10, probably it is a fibrinogen deficiency. In X10, the A5 is pretty robust. Can you see 45? So 10 goes to 45. So good platelet function. But the problem is with fibrinogen. So what will you do again? Transfuse fibrinogen for obstetric bleeding. So just keep in mind the obstetric cutoff for A5 in most of the centers are more. So you need a higher A5 for obstetric bleeding. So at least by 2. So in normal patient who are bleeding, we look for A5 of 7 or more. But for obstetric, it is 9 or 11. Okay, so slightly higher. Okay, right. Let's go to the next one. Any takers for this? The clotting time is 4059 in the 15 and you don't have anything in the 15, just like a straight line again. So this is the usual thing that you see, all right? So it is a fibrinogen deficiency again. So I'm showing a lot of fibrinogen deficiency because it is very common, okay? So the way you can find a fibrinogen deficiency, one is A5 will be totally gone. There is no A5. The other one will be a clotting time high, and this can also be present if there is a hyperfibrinolysis. So there is no fibrinogen and the clotting time is very deranged, and you will get a maximal clot lysis more than 5% here. But this one doesn't have a ml of 5% or more. So this is probably only fibrinogen deficiency. Okay, got it? Early fibrinolysis, you can see that. So you again supplement fibrinogen in this case. What is this one? Quick, quick. What is this one? This one. Somebody has pointed. What does that mean? 100%. So again, fibrinolysis. How will you treat is any answer? How will you treat this? Tranexamic acid. Right, correct. Okay. Now next. 60-year-old woman who was admitted with subarachnoid hemorrhage is less responsive after sudden gush of blood into the EVD. How would you proceed? That's her Rotem. Interpreted again. Clotting time. These are all practical cases, so very, very, very high. What's happening with the ML here? 99%, 6% in Eptem. Okay. Again, fibrinolysis, tranexamic acid. What's happening with this one? Can you take us quickly? So 15 A5 is normal. Okay, what does it say? Factor 7. Okay, factor 7 deficiency. I cannot make out what is factor 7 deficiency, right? We talked about this. Now in INTEM, what is happening? The clotting time is abnormal. It gets corrected in HEPTEM. Okay, what does that mean is the patient has heparin on board, right? The INTEM, which is completely abnormal, gets corrected in HEPTEM. That means there is a heparin effect. So you give Rotem into this patient. Okay. This one 56-year-old man post-reduced sternotomy for AVR and cabbage. Drain output is 400 ml in first hour. What are the next steps in patient care? Okay, what's happening here? Again, just look at the star one. So, in lysis is 9%. So again, there is increased lysis. Though it looks fat and wide, but you have a clot lysis of 9% and the patient is bleeding. So what will you do? Tranexamic acid. All right. Okay. This one, we talked about this already. So in TEM, the clotting time is 1500, which is abnormal. In HEPTEM, it gets corrected 138. So what is this? Heparin effect. Okay. So what will you do? Give protamine. Very common in the exam. Okay. What is this one? This is important one. Now see this bottom line here. I'll just point out what is there. So in the INTEM, the clotting time is 268. In the HEPTEM, the clotting time is 369. Okay. Both are prolonged. And in the EXTEM, the clotting time is normal. We talked about this combination already. What is this? Yes, it's protamine excess. So what will happen? You'll have a prolonged time in INTEM and HEPTEM. EXTEM is normal. So you have given protamine in excess amount. So protamine in excess amount is a anticoagulant. Okay. So in excessive protamine use, you will have INTEM and HEPTEM prolonged but normal EXTEM. Okay. All right. I think this was the last example, I believe. Yep. Thank you. Thanks a lot for your patient hearing. And if you have any questions, I'm happy to answer. Otherwise, I will hand over to Tapas, who will be talking about the next session or whoever the speaker is. Thank you. What
Hello.
about what about other numbers? Uh, Previous two slides answers. We discussed about that already, didn't we? So this is the question. You mean this one? So this is the heparin excess because you have your clotting time is high in the INTEM, that gets better in the HEPTEM. So that means if you put heparinase, the clotting time gets normal. That means there is heparin excess. So that's the one, and the previous one before that is this. So this looks normal except for the clot lysis, maximum lysis ml. So 9%, which is more than 5%. That means the patient has ongoing fibrinolysis. You give tranexamic acid. Okay. Hope that makes sense.
Yeah, Dr. Hamid, we will be sharing the recorded session soon after editing. So just bear with us for the editing purpose. But please attend it live and hopefully this would be more useful to you.
Somebody has told Tapas that in my EDIC exam I could not see any number. I just saw pick and guess what happening. Okay, so you need to know the what do you call the structure of the champagne glass. Okay, you just Google on the you can Google it and see Rotem champagne glass format. So there are two or three things that you need to know. We talked about that already. So this is the usual. Even if you don't see the numbers, it's pretty self-explanatory. Like I'll show you. This one is fibrinolysis. As you can see, a flat line in the 15. So you don't have to have anything there. Okay. Even if the no number, you can see this is fibrinolysis or fibrin deficiency. This is again late fibrinolysis. You can see this type of what do you call picture. This is late fibrinolysis. Then this one, the first one here again a straight line. Same fibrin deficiency or fibrinolysis or early fibrinolysis. Um, this one again, you have a narrow fibtem, so that means there is fibrin deficiency. So you need to know what channel you need to see and what are the abnormalities. Just Google some pictures. You'll be well acquainted with that. Sometimes you may not find the numbers.
I have that. If you like, I can share. Just one
Yeah.
second. Yeah, I will be showing you. Is it visible?
Not yet. Yes, now you can see it.
Yes. Yeah, Sanant, you can go through this one and explain if the candidates expect any answers. But I think after your so elaborate discussion, the candidates would be now more clear about the structure, how to approach, and also this is the different champagne bottle, the glass, and you can how you can guess what is happening. So this is the common Rotem patterns. This is brandy snifter. This is
That's
the
the
normal
normal
format.
one.
Yeah.
Then,
Then the
if you have factor deficiency, your clotting time will be prolonged, as you can see here, before it goes up. So this is the clotting time is prolonged, the stem of the champagne glass. Fibrinogen deficiency, in that case, your A5. So A5 is low, 5 minutes, A5 will be low. Okay. So in that case, you have to give fibrinogen again. Thrombocytopenia, again, I mean, I told you about, so this is going parallel, it doesn't go up like this. Can you see how it goes up in the wine glass, in the brandy? It goes up in a tangent with a good alpha angle. If the alpha angle is not good and it goes parallel, then it is a thrombocytopenia. Okay. Fibrinolysis, as you can see, it is narrowing down. So inverted Martini glass. So it's easy to remember if you can see these curves, but practically you need to have numbers also. I don't know what will you get in EDIC exam, but you may get it without the numbers, and they can give you that also.
okay, perfect. Thank you, Dr. Sanant, for taking your time at I think 11:30 or 12 midnight now. There, 12:30, I think. Okay. So if you have any doubts, you can post it in the chat box, or also you can post in our various the social media as the WhatsApp groups, and we will be definitely getting back to you with more resources. So with this, I would be now inviting Dr. Jitendra C from Apollo Hospital, Bangalore, dear friend and colleague, and he will be talking about again one more important domain, so just like related to the heart, and that is intra-aortic balloon pump. Over to you, Dr. Jitendra.
Thanks, Professor. And good evening, everyone. So after this elaborate discussion on one of the hot topics in CBS questions, that is Rotem. So now we'll go into another hot topic. You definitely will get a question on IABP. I mean, few exams, there has been a question on IABP. So that is why we'll be going in a little bit detail on this, and mainly we'll be trying to show you to this range of questions you can expect in the exams in this particular topic. And I'll be and we'll make it a little interactive so that it will be. I mean, we'll come to know where we stand before the exams. So is my slides visible?
Yes, Dr. Jitendra, yes.
Okay, sir. And I'm audible.
Yeah, you are audible, but I think there is some echo happening because two of our the attendees have written like the voice is not clear. Though I can hear you, but something is happening. So you can uh,
Just check.
yeah, your voice is audible, that's for sure. But yes, this is not very clear. Agree.
Okay. Now any better, sir?
It's better. It is audible. I think you should continue.
Right. So another factor in CBS is about IABP. So though you see, let's say it has been downgraded, but still one of the most common mechanical circulatory device which you use and which have been used in multiple places. It is the most commonest one. So whatever be the level of evidence and recommendation. So today we'll be discussing, and this will be our agenda. So we'll discuss about hardware and the monitor. Because sometimes you get questions where they display the monitor screen and ask you what is the finding there. Next, we'll discuss about the waveforms, which is the most commonest and commonly asked questions, and little about the physiology. So, because if you understand the physiology, it's easy to answer any abnormalities you see on the waveform. And then indications, contraindications, little about the complications. And I said the errors in timing. So the most common question which is asked. Little about the evidence, because not only that, you can be asked about
Dr.
IABP.
Jitendra, Dr. Jitendra, if you can come to little bit nearer to the laptop maybe, or the candidates are having slight difficulty that the voice is not clear. It is audible, but yes, if you can do something, mm, or maybe you can just go a little bit slow because the
Yes,
echo
now,
is
sir.
actually, yeah, I think this is better. Yeah, yeah,
Okay.
yeah, perfect.
Okay, so again, I'll repeat the same. So that's what we'll discuss little about the hardware and monitor. So because as I told you, monitor images will be shown in the exam to pick up what is the abnormality seen. So little about that. Then the waveforms and physiology. So how you get those waveforms, what is the physiology behind it. Then the indications and contraindications. Some complications which are common because I mean, it's a procedure being done. So any procedure, as you know, EDK exams, you will definitely be asked about the complications associated with it. And here we have waveforms, and we know there are errors in timing. So that is what is a hot topic in IABP. So errors in timing, you'll have to identify the error in timing and what you do and how you recognized it. That is what they'll be expecting in your exams. Next, little about the evidence, because now it is evidence-based medicine, and any question they ask, they you can expect them to ask about evidence. And next, I'll discuss the most commonly asked questions also. So that is what is the agenda for today's discussion. So, and as I said, we'll keep it interactive because otherwise it'll get very boring. And when you are interacting only, you'll come to know so where you stand. So what are your mistakes you do, and there's no exam. So you can definitely do some mistakes here so that you will not be repeating it in your subsequent exams. Okay. So this is the console how it looks. So I'll not go into details of this. This is how it looks on the back of it. You have a helium tank there. You have some fibers running there. So this is how it looks. And you have a console and you have a display there. And next to the display, you have a interface where you'll be using multiple buttons to make some adjustments in your settings. Okay, so this is how it is placed in a 3D image. So this is our IABP balloon, the tip of the IABP balloon. And where should it be placed? Anyone who wants to take the answer? Where should the IABP balloon be placed? What is the optimal position for the IABP balloon? Anyways, I'll be discussing it. Okay. So this is how it is placed. So it will be just 2 to 3 centimeter distal to the offset of your left subclavian artery. That is where it is should be positioned. And I'll be discussing little later. So this is how it looks in the real time. So this is the arch of aorta, descending aorta where your balloon is.
Dr. Jitendra, if you can make it in the
Yes, sir.
Zoom, like your
Oh, sorry, sir.
slide is, yeah, yeah,
Yeah,
yeah.
sorry, sir. Okay, yeah, now it is better. So this is the console's picture, the display picture. So the top one is the monitor of your console. So the top green line is your ECG, and you get the heart rate from the ECG. Next, you have your arterial waveform, and next below that arterial waveform, the one in yellow is your arterial waveform. It can be in different colors, that doesn't matter. So next below that in blue is your IABP inflation waveform. So the balloon pressure, what is the pressure in the balloon? That is what will be displayed in that. Coming to the interface, in the interface, you have various modes which are there. You have the trigger settings, the frequency, the augmentation, the various things which are there on your console. So this is how it will be looking on your. So you can get an image of this also. They may put a display of this and ask you what is the trace. Okay, so this is, and everybody can see this is a 1:1 augmentation. So I'll tell you what this 1:1 means and all. And next is, you can see the pointer here. So this is the timing. So you can set your inflation deflation using these buttons here. And this is your augmentations. Here you can see there is complete LED, all the LEDs are glowing here. So that means there's 100% augmentation. And what is the ratio for your augmentation is 1:1, 1:2, 1:3. And from the picture, that is also commonly asked. I mean, no need to get frightened when they say it is a question on IABP. Sometimes they keep it very simple, not to worry much about it. They may not ask you about the timing or interpret your waveform. They may just simply ask you, so what is the augmentation in this particular picture? So what is augmentation? Anybody wants to tell? So you can write it in your chat box. So this is 1:1 augmentation. You can see every wave there is augmentation. So that is 1:1. I'll show you. I mean, and another thing to remember is whenever there is a IABP waveform, to interpret the waveform, you require at least a 1:2 augmentation. You can't interpret your IABP waveform. I mean, you can't explain what is happening with your end diastolic pressure, what is happening with your diastolic augmentation. You can't be able to comment on it unless you have a unassisted wave. So you should have an assisted wave and unassisted wave. Only then you can tell what is the effect of your IABP. So usually if they're asking you what is the effect of this, then they'll give you at least a 1:2 augmentation. You can't interpret it on a 1:1 augmentation. Okay. So these are the various buttons and display what you see on the thing. Okay, now coming to the thing. So this is how your 1:2 will look. So you have a unassisted waveform. This is a normal arterial trace. You have a upstroke, you have a peak, then you get a dicrotic notch, and then you comes to the diastole. So next is another waveform. Here you see there is some changes in the waveform. That is because your IAPP balloon is inflated here, and this is a assisted waveform. See, when there is assistance happening, so your IABP is help the heart. So with that, what is happening? You are having a augmented diastolic pressure. So you see that the diastolic pressure goes high. This is an augmented diastolic pressure after your balloon inflation. And next you come to a lower pressure than the previous waveform. This is your assisted diastolic pressure. So your diastolic pressure comes down after the assistance which has happened. So your inflated balloon helps in increasing the diastolic pressure, and then your assisted diastolic end diastolic pressure comes down, which makes the heart to function better because the afterload is coming down. And apart from that, you also see that the assisted systolic pressure comes next. So that is less than your unassisted systolic pressure. So as we see further waveforms, you'll be seeing it. And so what is this augmentation? This is a 1:2 augmentation. You can see this 1:2 augmentation. That is every alternate beat is being assisted. So this is your unassisted, next comes assisted, next the unassisted, next assisted. So like that it comes. Okay. So you require at least a 1:2 augmentation to interpret. In other parts, helium tank. So, what are the commonly used gas is helium. What are other gas you can use for IABP inflation? And they may ask you questions on why helium also. So helium we know is a less viscous gas. It is so because it is less viscous, it can easily inflate and deflate. So the say somebody's heart rate is 100, so within less than a second it should inflate and deflate. So that fast happens only when the gas is well less dense. So that is one of the reasons why helium is used. So other than that, so it is a very absorbable gas. So by chance if there is a balloon rupture or leak of helium, so that will get absorbed. So if it doesn't get absorbed, what happens? You'll have air embolism and it will lead to complications. So to avoid that, we use helium. The other gas which can be used, which can sometimes be asked in your exams, is you can use carbon dioxide also. Okay, so these are two gases which can be used in your IABP apparatus. So this is the magnification of the waveform. So you will be seeing an arterial trace and you will be seeing a balloon inflation. This red color is your arterial trace, and you can see the gray color underneath your red color trace. This gray color is an unassisted normal arterial waveform. Okay, so here is a dicrotic notch, and when your patient is being on IABP, you would have timed it to in such a way that your balloon will inflate at the dicrotic notch. Okay, so there is increase in your this increase in your systolic peak. So this is your diastolic augmentation. This is the augmentation which has happened because of your IABP waveform, and beneath that, for your to help you out, so you can see that the balloon is also inflating there. Okay, so these two are the waveforms which we'll be seeing on the console. Okay, it will not be seeing on the patient monitor. You'll be seeing this on the console, but the arterial trace can be seen on the monitor, on the patient monitor also if you're using a arterial line. Okay, so this is how it looks. Okay, what is this entire time frame? This entire time frame is the period of your balloon inflation. So balloon inflation, upstroke, it becomes a plateau, the balloon pressure becomes plateau, and there's a downstroke when there is deflation. Again, you'll have a pause for some time, and again another inflation. Okay. So this is with respect to the balloon waveform. So this is pressure versus time. So in pressure, you see the balloon is getting inflated and the pressure in the balloon is going high. And you'll see a balloon overshoot, balloon inflation overshoot. It'll go slightly high and come back. Let's say it is just like a ventilator waveform, which my subsequent speaker will be speaking to. So this is like your peak pressure on the ventilator waveform, and this is your P flat on the ventilator waveform. So it will initially shoot and then become a balance, and it will become a flat thing, and then it goes down when the balloon is deflating. So this is balloon rapid inflation and deflation. You have a overshoot and equalization plateau. So just like our ventilator waveform. Okay. So these are the various parts of the various parts of the arterial waveform. So what all you are seeing? So top one is your ECG. So usually usually commonly used trigger is your ECG. So usually we time it. I mean, you set a trigger. We will see what a trigger is. The trigger is what is initiating a inflation and a deflation. Okay, what is initiating a inflation is a trigger. The commonly set trigger is your ECG waveform. So where does your inflation happen? It will usually happen at the peak of your T wave. You can all see at the T wave, you can see there is inflation which is happening. and at the peak of R wave, that is just before your systole. So that is when your deflation happens. So just before your peak of R wave or just before your systole, you have a deflation because the heart should pump out blood. Okay, so inflation at the onset of diastole. So you can see it as a sharp V wave. So I told you with respect to arterial trace, it will coincide with the dicrotic notch, your inflation. Whereas with respect to your ECG, it will coincide with the T wave. Okay, at the middle of your T wave. So that is when your inflation happens. Okay, so we'll read what is the physiology in the subsequent slides. This is just to show you the uh, location of the inflation with respect to your ECG trace. Okay, inflation happens at your T wave and deflation happens at your just before your R wave. So that is when after R wave you will be having a systole. So that is when your deflation happens. So occurs at the end of diastole before systole, resulting in reduction of iron. I'll tell you the what are the parameters or the hemodynamic effects of these. Okay. And another point you should remember is these things which are there, the A, B, C, D, E, F. Sometimes they may ask you to interpret this, or they may tell you what is happening with the end diastolic pressure. So you should know what end diastolic pressure is. So what is A? A is one complete cardiac cycle. So it's from the time of deflation to the time of inflation up to the point E. From B to E is a one complete cardiac cycle. So where the augmentation has happened. So that is your one cardiac cycle. B is your unassisted systolic pressure. Sorry, unassisted end diastolic pressure. So before your waveform gets supported, that is your before your balloon gets inflated, you get the previous waveform and the base. The diastolic pressure is your unassisted end diastolic pressure. Unassisted end diastolic pressure. So the subsequent one which comes at E is your assisted end diastolic pressure. Okay. So after the assistance, you see that the diastolic pressure goes down. Okay. So before that, it is high. So you see the end diastolic pressure going down. So this is assisted end diastolic pressure. This is unassisted end diastolic pressure, which is little higher. Let's come to C is your unassisted systolic pressure. So here there is no assistance from the balloon. The balloon is not yet inflated. So this is your unassisted systolic pressure at C. So D comes your diastolic augmentation. This is the amount of augmentation which has happened. So the balloon is inflated at this dicrotic notch and the augmentation has happened. And you see that is gone slightly above your unassisted systolic pressure. Correct. So this is what is the finding you see. And finally comes your E, which is your reduced end diastolic pressure. And next is your F. That is your reduced systolic pressure. This F, sorry, there is no marking here. So this is your F, which is your reduced systolic pressure, which is seen in your assisted. So, okay, in an assisted waveform, you see the systolic pressure goes down. Okay, so these are the parameters. So remember these terms. So B is your unassisted systolic pressure. Sorry, unassisted diastolic pressure, end diastolic pressure. C is your unassisted systolic pressure. D is your diastolic augmentation. E is your assisted end diastolic pressure. And F is your assisted end systolic pressure, which is less than the unassisted one. Okay. So any doubts? You can stop me at that point, or I'll be repeating these terms again and again so that you will get it registered. Okay. So no need to worry about. So now we saw the waveform, how it happens. We saw the console. We saw the various parameters which are there on the console, how we set a console, and what parameters are there on a waveform. We saw the ECG correlation of your Iabp waveform. We saw arterial trace and the Iabp waveform. So now we'll see the various settings which can be made on the ventilator because this will be asked in an exam. They say they'll show you the waveform. They'll ask you to interpret the waveform and they'll ask you what should you do with the waveform. So you should know these terminologies. So you can see on the console, you have various settings which you can make. So what are the one is you can move, there is something as auto mode and a semi-auto mode. I mean, you can know by it. So auto mode is completely done by the machine itself. Semi-auto is you'll give some input and machine will do the rest. So other than that, you have something called standby, start. So these are there on the thing. Apart from that, most important thing that you should know is your trigger. So what are the triggers? I told you what is the trigger. Trigger is one which will start the IABP or it will start the inflation in the IABP balloon. So the common ones are your ECG. Next is pressure. You have a pacemaker. Next to only arterial pacemaker. Next you have something called internal mode, which is like a default mode. So I'll tell you when to use these. What are the advantages of these? Next, so based on the source, you can set what is the say ECG, you can select which lead to select. From the pressure, you can time your pressure. So the thresholds, all of this. Next is something called as IABP frequency. So at what frequency are you supporting the heartbeat? So every beat you support, it is 1:1 frequency. Every alternate you support, it is 1:2. Every third beat you support, it is 1:3. So we would have all seen this. So just a revision, that's all. Okay. And then next comes the amount of augmentation. So you can see in this, there are 10 LED lights here. So bottom one is, it is 10% increment up to the top. So one every LED light increases. You increase one, it will increase and maximum it goes up to 100%. So 10% for each LED light. So there are 10 steps here. So maximum is 100%, least is 10%. So you can increase or decrease the amount of augmentation, means amount of support which you are providing to the patient. So usually we keep the augmentation 100%. And usually when we are weaning off, we'll usually change the frequency than reducing the augmentation. So if there is any abnormality in the timing of your inflation deflation, so you have an option on the interface of the console, so you can change the timing of it. Here you can see inflation, deflation. When inflation, you can increase or decrease it. Deflation, you can increase or decrease it. So these are common settings which are there. You should know these terminologies. Okay, now coming to the triggers proper. So I told you the commonly used one is the ECG trigger. So you have a ECG waveform. From the ECG waveform, it will pick. I told you. So it is a preferred and the most reliable one. R triggers the deflation. So coming from the starting PQR, so in the R it will trigger the deflation, and T triggers inflation. So I told you inflation happens at the middle of the T wave and deflation happens just at the R wave or just before the R wave. So if there are any arrhythmias, what to do? So there are some newer consoles which will go ahead even with arrhythmias. So even if there are significant arrhythmias, it can go out. If the patient develops a AF, yes, irregular, what to do? So no need to worry. Some newer consoles have AF trigger also. So if there's AF on your patient, if the patient was sinus tachycardia till now or sinus rhythm till now, suddenly it develops AF or some tachyarrhythmia, no need to panic about it. You can change either you can change to other triggers like pressure trigger, or you can change to a trigger called AF trigger, which is there in some of the newer machines. So it will just support the patient at every R wave. Say rate is 180, so every R wave it will start supporting the patient. Okay, no need to panic about it. Even if the rhythm is abnormal, so it will still support the patient. So next commonly used trigger is a pressure trigger. I told you if there are some tachyarrhythmias, sometimes you can change the trigger to pressure trigger and you can time it there. So whenever there is poor ECG quality, that is when we'll consider. So sometimes you have very sweaty chest, hairy chest, or your ECGs are not picking. There's some significant pericardial effusion. The amplitudes are very, very small. So that is when you'll consider using your pressure trigger. So this is one of the things. Most commonly, whenever the ECG trigger is not working, that is when you go with the pressure trigger. So where do we trigger? I told you dicrotic notch is a trigger for inflation, and point just before systolic upstroke triggers the deflation. So at the dicrotic notch, you'll have an inflation, and just before the systolic upstroke, okay, just before the arterial trace upstroke, we saw that no end diastole, unassisted end diastole. So that is when you'll see that there is a deflation. So when do we commonly use it? During CPR. So what happens during CPR? We know there is no rhythm during cardiac arrest. So you can't, your IBP can't rely on the ECG waveform. So that time what you'll do, you'll change the trigger to pressure and you'll continue. So whenever you're doing CPR, you have arterial trace. So it is producing a dicrotic notch. So the IABP will continue to function with the pressure as the trigger. If it was ECG, you can change it to pressure trigger and continue your CPR. No need to panic about it. So next comes something called as internal trigger. So your ECG is also not working, your arterial trace is not great. Then you can put it to a baseline default mode called internal trigger. So here asynchronous rate without physiologic triggering, without any trigger, it will continue to give a trigger. Like say when it happens, say when your patient has a asystole. So there's asystole. What to do? You have a ABP machine. You are still preparing to start CPR. So that time you can put into internal trigger mode. It will only set. Usually it will be set at a rate of 80. So 80 beats will be supported. 80 times the balloon will inflate and deflate. So this can also happen when your patient is on a cardiopulmonary bypass. We all know there is a non-pulsatile flow during cardiopulmonary bypass. So during that time also, during asystole or during CPP, when your ECG and arterial trace is not great, so then you will put this patient on internal trigger and your patient will be supported by ABP with a basic internal rate. Usually it will be at a rate of around 80 beats per minute. So your patient has a pacemaker. So you have a pacemaker as a spike also. Pacemaker as a trigger also. So nothing, sir. We say you have somebody who's on IABP is coming by ambulance. You don't have a doctor there. So, but you can in that time. So you don't know the person who's there, a paramedical who's coming accompanied with the patient, or the doctor who's accompanied doesn't have any idea about the IABP. Then you can put this patient on auto mode and leave. So that will take care of the trigger part. Okay, so these are the commonly used triggers. I told you ECG trigger is the most commonest. Next commonest is pressure trigger, mainly used when ECG is not reliable or during CPR. Internal trigger when there is asystole or and the patient is on cardiopulmonary bypass. Pacemaker trigger when the patient is on a pacemaker. Auto mode when somebody with less knowledge about IABP is manipulating or handling the machine, then you can put them on auto mode. Okay. Or when your patient is in cardiac arrest, you don't know what to do, just put it on auto mode, it will take care. Okay. So we saw the various triggers. Next, I told you is level of augmentation. I told you we have those LED lights. which are there in 10 steps. 10 LED lights are there. So the least is 10%, the maximum is 100%. Usually, if you see, it will be kept in 100% because we want to give maximum augmentation. That is how much is the balloon getting inflated. So balloon should inflate not more than 90%, at least 90% should be inflated. So that, why is this important? It is important because the amount of balloon inflation is what is pushing the blood. The blood is getting displaced. So that is the blood which is coming back and doing the coronary circulation. That is what is helping your heart function. That is what is reducing your Iabp. So all this depends upon how much is the balloon getting inflated. So that is the level of augmentation. I told you usually we keep it at maximum 100%. So by default, Iabp augments every cycle. So that is what is default when a patient is very sick. So that is what you keep at 1:1 augmentation. How do I wean off my patient? So what do we do once the patient's condition is better, hemodynamics is better, his inotropes are stable or coming down? That is when we think about weaning the patient. So then we do 1:1, we reduce it to 1:2. So that is every alternate beat is supported. Instead of every beat supporting, you support every alternate beat. The patient is doing good on that. Hemodynamics are stable, no increase in inotropes. You can change it to 1:3. And usually after 1:3, so if the patient is stable, that is when we think about removing the ABP. So timings and adjustments should be done in 1:1. That's what I told you. Say you started your patient on 1:1. So I should know what is happening with the inflation, deflation. How do I do? So start with 1:1, change to 1:2. I told you you can appreciate what is happening with the hemodynamics and what is happening with the inflation and deflation only if you put it into 1:2. So change it to 1:2, adjust your timings, and then put back again to 1:1. And after that, when you're trying to wean, you can again change back to 1:2. Whenever you have any doubt about inflation, deflation, whether the timings are right or not, change the mode, change the augmentation to 1:2, see the adjustments, see the waveforms. After seeing that, again put back to 1:1. Okay, that is what you're supposed to do. Okay. So what does it mean? So, sir, you said, what is this augmentation coming down on augmentation? That means, so when the support from the machine is less, even then, if the coronary perfusion is good and the heart is doing good, that means that with minimal support also, the heart is doing good. 1:3 is the least support. In that, if he's doing good, that means that the patient can be weaned off from the IABP. So that is what it means. Okay. So a little more about the balloon. Sometimes they may ask you, how do you decide? So this may not be asked you in the CBS part. Sometimes in the CCS part, say somebody says this patient is in cardiogenic shock or heart failure, may require a circulatory support device. If you're commenting on IABP, then they may ask you, how do you decide on the IABP balloon size? The balloon size depends upon the patient's height. Okay, keep it in mind, not the weight of the patient, it's the height of the patient. If the patient's height is less than 152 centimeters, you use a 30 cc balloon. If it is 152 to 162 centimeters, it's a 40 cc balloon. If it is 162 to 183 centimeters or anything beyond 162 centimeters, it is 50 cc balloon. Okay, so use this. And why this size is important is because the anatomy, you should place the balloon between after the branching of the left subclavian and before the renal arteries. So that is what. And this length depends upon the height of the person. And that is why this size of the balloon. Okay, so that is why. So you should miss the left subclavian and you should not obstruct the renal arteries. So that is the logic behind it. That is why this balloon capacities. Okay. Now coming to how do I know the position? So that is usually done by radiography. You will be doing it in a cath lab. So you do a fluoroscopy and confirm it. Or after coming in the ICU, you can do a chest X-ray and confirm it. So in this two X-rays, in both the X-rays, it is not in ideal position. Usually the tip should be at the level of the carina, just below the carina. You can see here in the first image here, the IABP balloon has gone beyond the carina. See, carina is here, it's gone beyond. So it is gone too inside, so it will be obstructing your left subclavian artery. So you monitor the left subclavian pulse. So you'll see that the pulse is very feeble or absent. So that is because your LFPP balloon is obstructing the left subclavian artery. The ideal position I told you should be at the 2 to 3 centimeters from the at the level of the carina. Okay, just in and around the carina. Whereas in the subsequent, in the second picture, the carina is here, your balloon is too low. So here, so it is too low. It is obstructing your renal arteries. Okay, so in both the pictures, the balloon is not in position. When first picture, it is very too ahead. In the second picture, it is too distal. So you should push it a little more inside. Okay. So this can also be asked in your exam. So this is the X-ray, a comment on the things. Other than this, in this image, it's a radiology image. So you can see that the balloon is not in position in the other odd ways. But with respect to ABP, so the first one is too inside. The second one, it is too outside. So you should adjust the position. This may be asked in your exam. The tip should be at the level of the carina. Okay. So now coming to the physiology. So we saw the hardware part, we saw the how to time it, how to trigger it, how to augment it, how to wean off all those technical terms we saw. Now coming to the physiological benefits. Okay, during your So again, this may be or may not be asked in your CBS. So CBS, it can be part of your what are the physiological benefits. Sometimes they can be asking you in the CCS also. So you started your patient IABP, they may ask you about the physiological benefits. So what are the benefits of IABP? We all know it improves the coronary circulation. So reduction in LV stress and reduction in LV afterload after deflation at the systole. So there is sudden giveaway. So that will facilitate the LV. The workload suddenly comes down. That will facilitate the heart to work. They facilitate the LV to work mainly. So increase in LV ejection fraction because the afterload comes down, the LV ejection fraction becomes better. So cardiac output, how much does it increase? It increases up to 0.5 to 1 liter per minute or up to 30%. So there is increase in the heart rate. Increase in the cardiac output from the baseline, it increases by 30% or it increases in overall zero point 0.5 to 1 liter per minute. This will be asked when you're asked about mechanical circulatory support devices. Okay, each device you should know what is the increment in the cardiac output that will happen when you use that particular device. So they may ask you a question on Starling's curve also. What happens? Obviously, right side movement of the curve means the LV is becoming bad. So obviously, you're putting IABP to facilitate the LV. So you can blindly say it is leftward shift. Apart from what will happen, there is systolic unloading. And I told you, even the peripheral blood flow improves. When the balloon inflates and deflates, there is distal pushing of the blood that will improve your peripheral perfusion also. This is not very significant, but this is what they'll be asking. Another important question they'll ask you is what is the effect on RV? So the answer is there is no direct effect on the RV, but there is indirectly it will help. So because you're facilitating the LV, so there is some offload on the struggling RV. So some effect, some influence is there, or some help is there for RV also, but mainly it is for the LV support. Okay. So again, because it's a procedure, it's a external device, extracorporeal device. So they will be asking about the indications. You can broadly classify them to two categories of it. So one is for the cardiac failure to support your LV, like following an MI or intraoperative injury. A second one is to match your LV is okay, but there is demand supply. There's mismatch of your oxygen supply demand, and there's a significant amount of ischemic zone to reduce your ischemic zone to preserve the myocardium. So one is the myocardium is damaged and you want to support it, it is not able to function like in heart failure. The other one is to help or improve the supply demand, like in it is improving the coronary perfusion, so that will improve your oxygen supply. So these are two categories. The other, you can subdivide them. These are the other indications. I'll not go into detail of it. Broadly, you can classify into one supporting the mechanical function of the heart. The other one is improving the oxygen supply demand balance. Okay. Now coming to the contraindication, as I told you, any procedure they'll ask you about the contraindications. You should know the absolute contraindications. If they're asking you the question, these four should definitely be there because they'll be getting you the maximum marks. So what are the absolute contraindications? So aortic regurgitation, dissecting aortic aneurysm, large AV shunt, and patients with chronic end-stage heart disease, with you are not expecting any recovery to happen, then you may not be putting this patient on contraindications. We will not be starting him on IABP, so you should definitely know aortic regurgitation and aortic dissection. So related contraindications like peripheral vascular disease, aortic aneurysm, severe non-cardiac systemic disease, massive trauma. These are relative contraindications, but definitely they'll ask you about the absolute contraindications. Okay. So they may ask you, so this patient has a FEMPOP in place or peripheral vascular disease. What do? You can try the other vessels. Okay. You can try the brachial, you can try the internal iliac. So like options like that are there. Okay. So again, and any procedure. So you will, whenever they ask you the complications, we always tell in our course. So it is always better you classify them, you divide them, you categorize them, and you can categorize them during any procedure for that matter. So it is intubation, ICD, defibrillation, any procedure for that matter. So you classify them into you categorize them. So during insertion, during its use, and during removal. So it will make your job easy, and you'll get two answers for each. So that will cover most of your answers. Okay, you will not be missing anything. So if you blindly answer, so you may miss certain important points. So if you subdivide them, so it is easy for you to answer, and you'll get multiple answers. So coming to the complications during insertion. So what one, it can be distal peripheral bad peripheral vascular disease. You may not be able to canalize it. It is very common because it's a pretty big cannula will be inserting, a pretty big sheath will be there. The balloon should go. If the vessels are damaged, there is significant stenosis, then you will not be able to do. That is the most common complication you will be seeing. Sometimes if you injure the aorta, it can cause aortic dissection. Malposition, I have told you, very important, can lead to it. Malposition can happen anytime. Okay, during insertion or during use also it can happen. So you should be very careful. You can tell that in both the cases. Axial femoral vein cannulation can also happen when you are not sure about the structure. So next, during the use, I told you it is a extra. It's a external device in the patient's body. Sometimes people use anticoagulation, but most of the centers they're not using anticoagulation. There is high risk of thrombosis. So peripheral embolization is possible. Once the thrombosis form, it can get dislodged. Incorrect position. I told you, if the patient moves his head, flexes his leg, or you extremely flex your patient's upper body, that can lead to dislodgement or movement of the balloon. So you should be very, very careful not to move much, not to usually keep him well sedated and restrain the leg so that he doesn't move much. Infection, if you're handling it in an aseptic way, you will get. So high risk of infection. If you're not following strict asepsis, then there is high risk of infection. Perforation of the balloon can happen, but very, very rare. So balloon rupture, balloon gas embolization, hemolysis and thrombocytopenia is a very, very common complication occurs. Some amount of hemolysis happens because the balloon is causing trauma and it will cause damage to the RBCs and the platelets. So and thrombosis is there. So all of this can lead to some drop in HB, some drop in platelet count. Peripheral neuropathy can happen, and timing error. I told you when you're using it, so timing error can happen anytime. So always check. How do you check? You put the patient, if he's on 1:1, change to 1:2, check the timing, and again change back to 1:1. After removal, what can happen? Yes, obviously you punctured a big vessel, removed a big catheter, so there is risk of bleeding. So complete occlusion, 20 minutes, pseudoaneurysm can happen, fistula can happen. Sometimes your balloon can get entrapped. You kept the balloon for a longer time, some calcification has happened. So there is already a calcified vessel. So some thrombosis can happen, atherosclerosis can happen. That can trap the balloon. That is also very, very rare complication, but that can happen. So always whenever they ask you, so about the complications, time them. Okay, so during insertion, during use, during removal. Say for tracheostomy also, say during tracheostomy, after tracheostomy and post decannulation. So like that, you can time them and you'll get multiple answers for that. So that will I mean, you'll be covering most of the options with the examiner has. Okay. Now coming to the part, so we have discussed the theory part. So now we'll go into what are the commonly asked questions. I told you the commonest questions which I asked about IABP are timing of your inflation and deflation. So this is again, I've told you, I've already repeated this in the previous slides. Again, I'll be reinforcing it here. So what is this augmentation? I told you if they have asked you about the IABP waveform, to interpret IABP waveform, it should be in 1:2 augmentation at least. Okay, you can't do the interpretation on a 1:1 augmentation. So I told you where should the inflation happen? The inflation should happen on the, so this is arterial trace. So where should the inflation happen? The inflation should happen at the dicrotic notch. So you'll see a sharp V there. So that means that the augmentation is absolutely fine. After that, what happens? You'll reach the diastolic augmentation, that is peak. That will be very higher than your previous unassisted systole. Okay, so this is your unassisted systole. This is also unassisted systole. So your diastolic augmentation will be more than your unassisted systole. So that what is the help of that? That is what is doing your coronary perfusion. That is what is improving your coronary perfusion. So that is the thing. After that, you see the balloon gets deflated and you see that the pressure is not falling straight down. It is going slowly and coming down. I mean, it is not a straight line down. It is slightly steep. I mean, it is going like a peak like that. Okay, so you should remember this because once it goes down straight, that means there is some error in that. I'll be discussing the subsequent slides. So after that, what happens? There is gradual decrease in the pressure and then you reach a bottom, and that is nothing but I told you your assisted end diastolic pressure. So that is what is decreasing your patient's afterload, or that is what is reducing the patient's myocardial oxygen requirement. Okay, so and you can see this point is less than the previous unassisted end diastolic pressure. So this is the assisted end diastolic pressure. This is the unassisted end diastolic pressure. You can see that the diastolic, you will also have seen in your waveform, correct? In arterial waveform, you see that the arterial pressure before IABP and after IABP, you see that the diastolic pressure is significantly low. You would be thinking, is it some sepsis or vasodilatation? That is not the answer. The answer here is because of your balloon getting deflated, you see that the end diastolic pressure comes down below the unassisted. Okay, so you see there is diastolic augmentation which goes above the unassisted systole. And you see the end diastolic pressure goes below the unassisted end diastolic pressure. These are the two common things you should always remember. And what is the purpose of this? Diastolic augmentation is one which increases the coronary perfusion, and your diastolic pressure going down is one. When the balloon deflates is one which will reduce the afterload or reduce the oxygen demand by the heart. And next is your again unassisted beat. So again you get your assisted systole. So again, so this is how it continues. Okay, I've already described this. So what should be the significant drop? I told you the diastolic augmentation at least should be 15 to 20 millimeters, and your end diastolic pressure should drop at least by 5 millimeters. So this is the most important one. Okay. So anybody now starts the questions. So we'll keep it interactive. So anybody, see, I put the normal graph also for your easy understanding. So anybody wants to answer this, you can put it in the chat box. So am I seeing the notch? I'm not seeing the notch. Okay. So what is this? So and you are seeing, so there is this unassisted systole, and immediately after unassisted systole, you're seeing there is augmentation. So what is it? Anybody? I can't see any answers. Yeah. So already there, few questions we have. So this is early inflation, right? So you can see before the dicrotic notch itself, the augmentation has happened. Okay. So see, this is what it is. So next comes, this is first thing we will be asked in your CBS question. So what is the abnormality? So it is early inflation. Okay. So what next comes? What? How do you say it is early inflation? What are the parameters which are happening? So mainly they're asking you about what is happening to diastolic augmentation, and they're asking you what is happening to the aortic and diastolic pressure. So that is what they'll be asking. And because of this, what is happening? So what are the hemodynamic effects? So these are the two things. First, they'll ask you to identify the timing abnormality. Next, they'll ask you what are the hemodynamic effects of it. Okay, so what is happening here? So you see that the ABP is getting inflated even before the dicrotic notch. So what is happening here? So when the uh, so this will lead to premature closure of the aortic valve. So what is happening? The heart is made to work against the closed aortic valve. So this will lead to aortic resuscitation, increase in afterload, increase in myocardial oxygen demand. So all these happens. Okay. So what do you do? They'll ask you, what do you do for this? So what do? You'll go to the console, put it in 1:2 mode, and you, time the inflation. Okay, you make it to time when you bring it to inflate a little later. Okay, you adjust the time. I have shown you on the console how to do it. Okay. So next one. So anybody wants to take this? You can see there's a dicrotic notch. You can see after that there is some wave coming. You can see that the diastolic augmentation is not significant at all. And you can see assisted systole is less. So what is then? I think I have got some answers. It is late inflation. Absolutely right. So you can see after the dicrotic notch, after some delay, there has been some inflation. So yes, the answer is late inflation. So what do you see because of that? So yes, what do you see? You don't get the sharp V, correct? You're supposed to get a sharp V at the dicrotic notch, but here you're getting it little late and it is not that sharp also. So what happens because that I told you the diastolic augmentation down is come down. So I told you what is the importance of diastolic augmentation. I told you diastolic augmentation is one which will lead to coronary perfusion. Because the diastolic augmentation is less, you can see the unassisted systolic pressure and diastolic augmentation is less than the unassisted systolic pressure. So what will happen? The coronary perfusion will be very, very less. Okay, so how do you do? Now again adjust the timing. So ask the balloon to inflate little early. That is what you will be doing. So next, anybody wants to take this? Yes, anybody? So somebody said normal. No, normal is one in the blue, which is there. Somebody says early deflation, steep slope. Yes, see early deflation. So it was supposed to not slope like that. It was supposed to slope little slowly, but it is slow. So what is happening here? It is early deflation. So the balloon is getting deflated too early. Okay, so that means it was supposed to provide some support. Before it would complete its support, it has already got deflated. So what is happening because of that? So it will lead to you don't get significant diastolic augmentation. So it is not very effective. So the afterload reduction doesn't happen. So what is happening even before the LV starts pumping the blood, it has already got deflated. So what was it supposed to do? It was supposed to get deflated at the start of systole. Okay, but it's got deflated before that. But now the LV has to pump again the same afterload. So there is no reduction in the afterload. So what is happening before because of that? There is increased myocardial oxygen demand. So what do I do again? I time it. So I time it and bring it down to that position. If you can't time it, you are very lazy to do that. You can just put it on auto mode. It will only optimize it. Okay. Last one with the timing. So what is left behind? So this is the thing. What is happening here? So anybody? So this is late deflation. You can see very late it is getting deflated. I mean, it is easy. So obviously there are only 4 errors in timing. So I finished 3 of them. So it is easy. But in the exam, you should appreciate the waveform. Only then you'll come to know. Okay, you will not be having a normal waveform there. You will only have this waveform and you will be having 1:2 augmentation. So you should see what is happening here. Okay. So this is how the waveform looks. Prolonged rate of rise of assisted systole. So slowly it will rise. Okay. And you see that the assisted end diastolic pressure is almost the same. It is not reduced. Correct. I told you it should get reduced because the heart should get support. So because of that, what is happening? The heart is doing more work. Okay. So how do you adjust it? So you will adjust the timing. Okay. So this is how it is done. Okay. We finished the timing errors. So we have already discussed the weaning. I'll not repeat it again. Okay. So now let us go to the most important part, evidence. Okay, in the CBS itself, say they may ask you first question, comment on the IABP waveform, how do you adjust it? Next question can be, what is the evidence for it? So you will definitely be asked about evidence. So in any therapy, any mechanical circulatory support devices which you use in cardiology, everything they'll ask you about the evidence. So the common evidence which we have is, you all know about it, is IABP Shock 1 and Shock 2 trials. So what is the, I have put the bottom line. The bottom line was there was no survival benefit. Okay. And this was done in 2014. That time itself, they have downgraded. If you have seen, so there was a higher recommendation for using IABP in acute MI patients with or without cardiogenic shock. It was a class 1 or class 2 recommendation initially. But after this IABP shock 2 trial, you can see that the Kaplan-Meier curve is showing no gap between. So that means there's no mortality benefit. And there was actually much increase in incidence of some adverse events as well. So that is when they downgraded it from class 1 or class 2 in A, class 1A recommendation, they downgraded it to class 3 recommendation. What does the class 3 means? Class 3 means the risk is more than the benefit. So that is what is the recommendation currently. So there's not much of a risk, or some adverse events are more when you're using IABP. That is what it is. So another study, so balloon pump assisted coronary intervention study called BCIS. So this is the study. So they saw any patient with going to PCI, any high risk patient going for primary coronary intervention, they wanted to put IABP and see what will be the effect. This study also showed that with IABP, without IABP, IABP was not much of an help. So there is no role for prophylactic use of IABP. So, I mean, you need not start IABP on a high risk primary coronary intervention, assuming it will help. But they saw that in this particular study, there was no evidence at all. So starting a patient on IABP, then doing PCI, or just going ahead with PCI did not make a difference. So that means this study said there is no need for prophylactic IABP in any patients with high risk PCI. Okay. Another large study which was recently published in your Journal of American Cardiology. So this is the study. So what was the study done? It was a very small study. So where they looked into standard care, that is routine care, and with IABP care for any patient with cardiogenic shock. So and in heart failure due to cardiogenic shock, they saw what is the effect of IABP. And in this, they said standard of care alone is adequate. So as you can see again in the Kaplan-Meier curve, there is no gap between the waveforms, so there is no mortality benefit. They said even standard of care alone is adequate. No need to go for any mechanical circulatory support devices. So IABP did not have any benefit. Okay. And last one, so there's something called Protect 2 trial. It's an RCT. So they were mainly looking into the adverse events. So they compared two circulatory devices. One is your IABP and the other one is your Impella. The problem here they saw is your IABP had more adverse events. Okay, and you saw the mortality was little higher. Sorry, the adverse events were higher. This Kaplan-Meier curve is about the adverse events. So they saw IABP had very high complication rates or adverse event rates compared to Impella. So they said Impella is much better than your IABP. The adverse events, not only about help in cardiogenic shock, the adverse events rates were also very high in your IABP patients. So these are other studies. I'm not going to detail of it. So you should know the name of the studies and what is the outcome. So conclusion is none of the studies showed any benefit with IABP. Okay, there is no mortality benefit. Few studies showed there was some significant amount of adverse events. But finally, all studies till now, there were no mortality benefit. So if you don't remember the studies, you should remember IABP Shock 1 and Shock 2 trial. If you don't remember the other studies, it is still fine, but those two studies should be noted and there is no mortality benefit. Okay. Now coming to, again, whenever there's some recommendation, they usually ask you about the guidelines. I told you in 2014 itself, it was downsized in the European Society of Cardiology. So this is the guidelines. What do the guidelines say? Usually they ask you about European guidelines, but this is the overall guidelines about IABP. The latest one is from ACC-AHA. It is in 2025. So in the management of acute MI, routine use of IABP in cardiogenic shock has been, again, I told you, it was a better recommendation. I think it was class 2 previously. Now they made it class 3 recommendation. That means it is not effective and may be potentially harmful. That is a recommendation for this. similar guidelines, similar recommendations from North American Society or the European Cardiology Society also. The latest guidelines from European Society of Cardiology was in 2017. I told you after the IABP Shock 2 trial, and they have downgraded it to class 3 recommendation. Okay. So let us go into a few more serious questions. So we saw the technical aspect, we saw the console, we saw the various parameters, how to adjust, how to read and all. And we saw the common CBS questions, which is about your timing of the ABP. We saw a little about evidence. We saw the guidelines. Now the common CBS questions. I want this to be very, very interactive because last few slides, I'll have some 7 questions. So with the 7 questions, I'll be finishing this. So if you make it interactive, because this is no real exam, so you can make some errors here. So if you make some errors, you'll remember in your real exam. Okay. So let us see these questions. So the first question. So I've not made the questions big. Okay, because of the time constraint. So I've kept it very, very small. You don't get so small questions in your CBS in your real exams. So I kept it small only because of the time constraint, because we have 4 topics to be discussed. So I kept it very small. So I can put a big case. You'll have a case study. So this is a patient who's on so and so, so and so. So later on, the main point will be the catheter shows presence of blood. So what is the diagnosis? How do you manage? I'll see if somebody's answered. So suddenly you see that IABP balloon shows some blood. Yes, many of you have said it right. So it is rupture of the balloon. So that is what you see. So the answer is correct. So somebody said it is removed. No, there is rupture of the balloon. So what do you do? So correct diagnosis is rupture of the balloon. Because the balloon is ruptured, the blood starts entering the catheter, and you can see that the tubing of the IABP will also have blood. So how do you manage? Anybody? Remove or replace. Very good. So that is what it is. So change the catheter. So at the same time, you should be worried about embolism also, correct? Helium embolism is also a thing. First, you stop the console. You should not push further helium into it. So suggest balloon rupture or helium embolism, one of them. So immediate cessation of counterprocess. That's what I told you. First thing you do is stop the ABP machine. So it should not push further helium inside. So placement of the patient head down. Why head down? We all know air embolism. That is the common thing we do. Put the patient head down and IABP removal, and consider giving broad spectrum. Why? Though the outside of the balloon is sterile, but the inside of the balloon is not sterile, and gas chamber is not sterile, so there is a chance of infection. So your complete answer would be stop the machine. So put the patient in head down position, remove the IABP. If the patient requires support, insert a new one, and in the meanwhile also start him on some antibiotics because this is unsterile. This was the first question. So next, coming the second question. So again, you'll have a big history about the patient. I've not put the history because of the time constraint. So you'll have and ultimately the question would be, patient IABP, the console, produces the following alarm. You see a following alarm. So augmentation is below the limit set. Like how you get ventilator alarms, like ventilator tidal volume is below the limit set, or minute ventilation below the limit set. Here also you can get an alarm, augmentation below the limit set. Why do you get that alarm and what do you do? So I'll see what are the answers. Somebody says it is timing error. Check the helium level. Okay, next. Anybody else? Delayed inflation. So it is usually the alarm limits. One of the common things can be, so the alarms may be set abnormally. Either augmentation is set too high. You have expected too high, or there has been change in patient's hemodynamics. Suddenly the patient had some issue. So suddenly some acute thrombosis has happened, or new ischemia is happening. The heart function became less. So that is when you'll get this augmentation below set limit. I mean, you can understand this augmentation below the limit. So you say there was significant augmentation happening. Now you see that the augmentation not happening. Either the underlying heart itself, the only reason, if the machine is not having problem, the only reason is the heart function is gone down. So either you can suspect a new MI happening in your patient. Okay. So there was a significant augmentation happening. Suddenly you see that the augmentation not happening like it was happening before. That means either there's a machine problem or the heart has some problem. So one of the things you should adjust, you should address both of them. So if the heart is an issue, first you check the machine. If there's no machine problem, then that means that the patient's heart is going down or functioning is bad. So you should support it. Either you add a inotropic or a vasotropic agent and improves the performance of the heart. So next, again, you have a history, and then the patient IPP, suddenly there's an alarm on the console saying no trigger alarm. What does this mean? How do you manage? So there is no trigger. Suddenly you see that the machine is producing an alarm saying, okay, sorry, I got the answer. So what is happening here? So we'll still see what the answers are. Patient is moving, change the triggers. Correct. So if it comes, the management is to change the trigger. So that means either the ECG lead should have come out. So whatever is the trigger. So asystole is correct. Yes. Best thing is, if you don't know anything, change to auto mode, or you can change the triggers. Yes. I think most of you have answered this rightly. Change to auto mode is the best part. Yes, if you have auto mode, yes. Otherwise, you can change the trigger. Say ECG was there, so it is not functioning. Suddenly, your patient had AF, change to AF mode, or change a different trigger. That's what I'm trying to tell. So next question. So patient on IBP support doing good, suddenly has a cardiac arrest. So what do you do? This question I think you should answer. Has a cardiac arrest, what do you do? And next question, part of the question was, what do you do about IABP during defibrillation? So should I switch off the IABP, keep the IABP? What do I do? So somebody said, yes, correct. Put to onto auto mode. You can change to a pressure trigger. Very good. Auto mode is the safest answer. So what about defibrillation? I think first question, all most of you have answered it correct. Put onto auto mode, a pressure trigger is absolutely right. So what about the IABP during defibrillation? Should I stop the IABP and defibrillate, or go ahead with defibrillation, or change the current, change the position? Anything about defibrillation? Continue defibrillation, go ahead. So yes, that's the right answer. Go ahead with defibrillation. No need to do anything with the IABP. Leave it like that, and you can go ahead with the regular defibrillation. Absolutely right. I think many of you are answering it also. So ECG trigger becomes dysfunctional. I told you there is no waveform coming, so it will become dysfunctional. So change it to pressure trigger or put it auto mode. So whatever it is. So defibrillation can be safely performed with the IBP device functioning. So no need to stop or change anything on the IBP. You can completely go ahead with your IBP, with your defibrillation as you do it routinely. Okay. Next comes the fifth question. So patient on IBP support was doing fine. Suddenly patient developed tachydysrhythmia. So some abnormal tachyrhythmia happens. The IBP starts producing an alarm and hemodynamics become unstable. So what do you do now? I already discussed this in the theory part. So what do you do now? So already have some three answers. Put on auto mode, change the trigger. Yes. What trigger you want to change? Auto mode, yes. Anybody else? Any other specific trigger you want to put to? Pressure trigger, auto mode, defibrillator, pressure trigger, auto mode, yes. Okay. AF trigger, yes. So you can put to AF trigger. So take it arrhythmia up to 110 beats. Usually the IABP will perform well, but only when it goes beyond 110, that is when it becomes very difficult for the IABP to get properly triggered. So there are some newer IABP machines which will work good even up to 220 beats per minute. So that is there. Or as I told you, can change it to AF trigger, and you can see. And primarily, you can't do anything about the ABP. Only management is you should correct the underlying tachydysrhythmia. So start him on some antiarrhythmics or things like that. So that is what will be helping it ultimately. But for the IBP to continue to function, you change the trigger to AF trigger or put on auto mode and treat the underlying tachydysrhythmia. Okay. Last two questions. So another question, patient on IBP, suddenly there is shutdown of the console. So what do you do? Suddenly you see there's power cut or the battery goes off. What do you do? Yeah, somebody said mode in cardiac arrest. That is for the previous question. So what? Suddenly the machine goes off. So this can also be asked in your. Yes, anybody? So what do you do when the machine goes off? So battery is when you thought it is on a UPS, deflate the balloon, restart the machine. How do you restart the machine if it's some? So that's what if battery is also gone. So machine is complete shutdown. It is not starting. What do you do? They say deflate the balloon. Anybody else? Inotropes. Correct. Cardiac support you do. What do you do with the machine? Was the question. Increase vasopressor. So that's what you'll maintain. Medically, whatever is possible, you'll be doing. Change the machine. Yes. So that will all take some time. In the meanwhile, what you're supposed to do is you will manually inflate and deflate the balloon. How do I do it? You can take a 60 cc syringe, and based on what is the size of your balloon, you can inflate and deflate. This is not to support the heart. This is only to keep the balloon inflate and deflate so that it doesn't get clotted. Because we know if it leave the balloon there, it'll be prothrombotic, it'll clot, and that clot can get embolized and you'll have complications later on. You will do it manually using a 60 ml syringe, but that your intention is not to support the heart. It is not for cardiac support, but is only to keep the balloon moving so that it will not allow any clot to form. Okay, so this is another answer. And I think last question, again, I told you about the complications. They'll definitely be asking you the questions in any intervention you do. You will definitely get a question on the complications. So I put a small case history here. You'll not get so small case histories in your real exam. So somebody said any role of extra anticoagulation you can give, but already there is significant amount of anticoagulation, more than anticoagulation. because we all know, right? So even if you give anticoagulation, if the balloon is sitting there, a foreign body is sitting there, definitely it will lead to thrombosis. So you can give a for the anticoagulation if the risk of bleeding is less, but ultimately you should make the balloon move before you get another machine. You can do it manually. Okay. Yeah, before reading the next question already, I get some answers. So complications. So you get a question on complications. 56-year-old male patient on ABP for cardiogenic shock. Suddenly the sister comes to you saying the pulse oximeter on the left hand is not showing a reading. What is your diagnosis? I'll read the answers. Catheter displacement, do a chest X-ray, reposition it, correct. It should be at the level of the carina. Answer absolutely fine. I mean, you're all experts now. So yes, do a chest X-ray, confirm the position. Uh, and so that is not alone the answer. One malposition everybody says. The other possibility is there can be a thrombus. Correct. That is another answer. Okay. You first answer is definitely malposition. That is what you'll be thinking. So next answer is you should think about any thrombosis happening should also be taken care of. Mainly we are looking into something occluding the left subclavian. Either it can be the balloon because of malpositioning, or it can be a thrombus which is formed because the balloon is sitting there for a long time. Okay. These two are the answers you can expect. So that's the end of my talk. And as I told you, you'll definitely get, because last few exams we have been seeing, you definitely get a question on IABP. Even if could not get time to revise, you get confused, the image is not clear, don't panic. Read the entire question, because I saw one of the questions, did not ask anything about the physiology of IABP or anything like that. They just asked what is the augmentation on the console. I think that is the simplest thing you can answer. So you don't need to panic seeing a question on IABP, even if you're not prepared well about it. So don't panic. Read the entire question. At the end of the question, it will be very simple, like I told you. So last time they asked, what is the augmentation on the monitor? They did not ask about physiology of the monitor. They did not ask what is happening in the waveform. They just asked, what is the level of augmentation? The answer was 1:1 augmentation. That's all it was. So simple. So no need to panic. Okay. So you have some questions. I can take some questions uh, if we still have thanks. Okay. So
Thank you.
main aim of,
Thank you.
yeah. Thank you, sir. Thank
Yeah,
you.
yeah, Dr. Jitendra, you complete. Yeah, no problem.
Yeah,
Yeah,
yeah.
yeah.
So, just summary at the end. So, main aim is not to teach you people, because you already learned this, you're experts in this.